Thank you so much, Rochelle, and thanks everybody for joining us. This is so exciting. I'm so thrilled to be hosting this series, particularly with Dr. Julia Marcus here. So this is a series that is funded by the UCSF CFAR through a Boost Award. So many thanks to our CFAR. And the purpose of the AI for HIV series is to really help benefit the community of HIV researchers and community and provide this space to talk about innovative HIV research using AI. So we have the incredible Dr. Julia Marcus with us today, infectious disease epidemiologist and associate professor in the Department of Population Medicine at Harvard Medical School and Harvard Pilgrim Healthcare Institute, and an adjunct faculty at the Fenway Institute. Her research primarily focuses on improving the implementation of PrEP to prevent HIV infections and promote sexual health in the US. And most recently, Dr. Marcus has been leading multiple NIH-funded projects that include randomized trials on electronic decision support tools with an embedded HIV prediction model to improve PrEP prescribing in safety net clinics. She has a study on implementation of long-acting injectable PrEP and also really fascinating project on over-the-counter PrEP, on feasibility and acceptability of over-the-counter PrEP. So Dr. Marcus's studies have been widely cited by the CDC, as well as articles in many other publications. And her research has led her research on life expectancy for people with HIV has contributed to the Equal Insurance HIV Act, which is a California state law that promotes people with HIV, protects people from HIV, from discrimination by insurance companies. She also does research on hepatitis C, COVID-19, and among many other wonderful projects. So today we are joined by Dr. Marcus to talk about prediction tools for PrEP, the implementation at the point of care. Dr. Marcus, please take it away.
Thank you for the kind introduction and the invitation. Happy to be here. Thank you all for joining midsummer. I know it's hard to make the time, so appreciate it. And yeah, of all those projects, I'm going to focus today on the clinical decision support to be in theme with the kind of AI focus. So I'm going to be talking about our work on prediction tools for PrEP, and specifically on what we've been learning from implementing these tools at the point of care. So just in terms of like framing this, this is this great quote from an IOM report from decades ago that really highlights how hard it is for us to talk about sex and for providers and patients to be talking about sex. And I think that's one of many barriers to people getting more access to PrEP, is just how uncomfortable it is to have these conversations. So the ideal is that clinicians discuss PrEP with everyone who walks in the door who's sexually active. And this was a positive evolution of the CDC guidelines on PrEP, from talk about PrEP with just the people at substantial risk of HIV, which I think eventually, it became clear that that was not helping our cause here. Like, people don't really feel like they're at substantial risk of HIV. How do you identify people at substantial risk of HIV? People feel like, it just kind of adds stigma to something that we want to have integrated into routine preventive care. So we have this evolution to discussing PrEP with all sexually active people, but at least this one study from the VA where they chart reviewed everybody who got PrEP, 94% of the PrEP discussions were initiated by patients. And so it might be better in some other settings, but I think in general what we're hearing is providers are not initiating these conversations. And if you ask PCPs, why are you not talking about PrEP with your patients? They mainly talk about time constraints. If they have like a 15-minute visit, PrEP is not going to be high on their list when they're thinking about hypertension and diabetes and things that are much more common. Providers still have limited PrEP knowledge, discomfort, as I mentioned, and also biases about who's likely to benefit from PrEP. And that can kind of play into prescribing patterns. And then this difficulty of identifying patients who are likely to benefit from PrEP. And it's not like HIV treatment where you diagnose with somebody with HIV. It's very clear that they need treatment. They're easily identifiable in the electronic health record. Prevention is much more nebulous. So the kind of big picture vision here is to develop tools that are automated that make PrEP prescribing easy, efficient, and equitable. This is a screenshot from the Kaiser, an old Kaiser EHR out in Northern California, where you guys are. And this is just an example that it shows up in any EHR, a dashboard with preventive services that the provider needs to be thinking about in terms of whether the patient is up to date. And here the provider is being prompted about this patient needing a discussion about their cardiovascular risk. And this is based on an algorithm that's baked into the electronic health record that uses demographics and clinical diagnoses to say, okay, this patient is at higher risk of cardiovascular disease. Here's what went into that calculation. Here's a guide for having that discussion. And here's how you prescribe medication if it's appropriate. So you can imagine a row here for PrEP or HIV prevention or sexual health that has an algorithm baked in that tells the provider this patient is likely to benefit from PrEP. Here's how we made that calculation, here's how to have the conversation, and here's how to prescribe the medication. So that's the vision. The first step, and this was now years ago, was to see, could you actually use electronic health record data to identify people likely to benefit from PrEP? And the short answer is yes. So this was work that I did when I was at the Kaiser Division of Research in Oakland. And we looked at millions of members of Northern California Kaiser and used a machine learning algorithm to predict incident HIV diagnosis. And it performed pretty well. And this graph is showing you this is an ROC curve, and that top purple line is the full model that included a lot of different data domains. And the best model is going to reach the top left corner of the graph that's maximizing sensitivity and specificity. And then those lines that get closer and closer to the diagonal, which is the flip of a coin, are models that only included, to the extent that we could identify it, whether somebody was a man who has sex with men and STI-related variables. And we did that because along the way, people kept saying, we already know who can benefit from PrEP. We don't need to do all this work. We don't need to be collecting all this extra data. And so we said, okay, well, let's see, like, how does our full model compare? And it performed much better than these models that only include sexual orientation and STI-related variables. And that was particularly true for Black patients. And so this is not surprising because we know that risk prediction algorithms are going to underestimate risk in populations where risk is driven by structural factors, network factors, high prevalence in the network. That's not going to be detectable through individual level behaviors. So these were just a quick overview of the variables that we ended up retaining in our model. Demographics, and not just for the individual, but also looking at their neighborhood, social history, lab tests and results, going beyond HIV and STI testing, also looking at urine toxicology, medication use, including medications for erectile dysfunction and diagnoses, including psychiatric diagnoses, and then our favorite ICD codes that I would like to get rid of, high-risk sexual behavior, and then HIV counseling and education. And the idea here was to really bring in enough data domains that we were kind of getting at that structural risk and getting beyond just the individual level behaviors. And you'll notice these are pretty... There's not a lot of female-specific variables here, and I'll talk about that a little bit later. We were really focusing on the epidemic as it looks at Kaiser Northern California, which is really largely MSM. And we've since done work with other groups to try to improve prediction for women. So in parallel, while I was doing that project at Kaiser, Doug Krakauer, who is here in Boston, was doing a similar project where he was also developing an algorithm at Atrius Health, which is a general practice here in Eastern Massachusetts. And then he prospectively validated it, and it did well. And then what he did that was different from what I did was he externally validated his algorithm at Fenway Health, which is, I'm sure you guys know, a community health center here in Boston that specializes in care for sexual and gender minorities. And the question here was, do you have to develop a new algorithm every time you do this in every healthcare setting, or can you just develop one and translate it across different settings? And the answer is like, kind of in between. Ideally, you would develop a new algorithm anywhere you're going. If you don't have the resources, you can take an algorithm from a different setting and apply it to a very different population, and you'll have some drop off in predictive ability, but it's still better than nothing. And this schematic is showing just what the distribution of risk scores looks like from these models, which is that red line. The vast majority of people have very low risk for HIV. And then there's this inflection point where the top, 1 to 2%, you start to see this increase. And that's really where you would want to focus on efforts to deliver PrEP. So going back to this question of risk prediction for women, so the Kaiser model did not predict risk for women. It just didn't. And that was partly because we had very, very few female patients with incident HIV on which to train the model. And so working with groups in the South, we've worked on algorithms that do much better predicting HIV risk for women, still not as good, but pretty close. And we've done that just by having more women to train the model on, and then also intentionally including female-specific variables such as PID. So along the way, we have been talking to providers and patients about what they think about this approach. This approach has been somewhat controversial in the sense that ideally we would be talking to everyone about PrEP. That is the most equitable way to do this, and we want universal offering. But like I said, it's really just not happening. And to us, we feel like the next best thing is to try to prompt these discussions with the patients who are most likely to benefit, with the idea that eventually it becomes normalized, routinized, providers get used to this idea, and it becomes more front of mind. So in asking providers and patients what they think about this idea, we've heard mixed reviews. So this was focus groups with PCPs here in Boston, and they anticipated some benefits of prediction tools for PrEP. So they said, yeah, I think this would help me identify potential PrEP users who I would miss because I'm busy, that it would help facilitate those uncomfortable discussions about HIV risk, and that it could destigmatize and standardize risk assessment. And then they had concerns mainly about negative patient reactions, like patients saying, why are you asking me about this? Like, it's not cardiovascular risk. It's not bone density. It is more sensitive. And so there was some concern there. Concerns about potential breaches in confidentiality, and then concerns about the accuracy of model predictions. And I'm going to come back to that point because that has actually ended up being the most challenging barrier to implementing this in clinical practice. So just a quote along the lines of, these anticipated benefits. I think I should probably be offering PrEP to more people than I'm offering it to. So in that way, it would improve my practice and have me doing something I would like to be doing. All right, so what about potential PrEP users? And this was a study focused on men who have sex with men, and this was interviews. And some themes that came up, first was the need for providers to contextualize any information that they give patients about risk. So it turns out that if you tell somebody they have a 1% risk of getting HIV in the next 3 years, some people think that's really high, and some people think it's really low. And they really need context to kind of interpret that kind of information. And just to be clear that that's not what we're doing. We're not actually giving people information about predicted risk, but that was sort of part of the framing of this study. Like, what would you think about that idea? They had doubts about quantifying risk at a single point in time. I believe a direct quote was, "You're not God." Like, you can't tell me what I'm going to do tomorrow, which, that's fair. We can't. And also there was some belief that these tools could motivate behavior change. It gives somebody a sense of, or I'll just read this quote, which is kind of along those lines. I would think an HIV risk prediction tool actually could be helpful in a way. I mean, obviously, I would take it with a grain of salt, but I think it would help me understand where I am, how I've been doing. Do I continue on the course that I'm on, or do I need to readjust? And I'll just say we've continued to do this qualitative work along the way in every setting where we've been implementing these tools, with the understanding that perspectives are going to differ based on the patient population or potential users. So the USPS staff has now called for research on these tools, and they've noted that there are these instruments for predicting HIV risk that could inform decisions about PrEP prescribing. And they've said that studies are needed to verify the impact of these algorithms in clinical practice. I will say most clinical prediction models sit on the shelf. There's been tons of these developed that don't go anywhere. And in retrospect, I would say that's because it turns out it's really hard to implement them in clinical practice. I'll share some lessons learned along the way. But we did go ahead and say, all right, we're going to do this. We're going to implement this at the point of care and see what happens. So we started with a pilot study, which was really good because we learned a ton in this pilot. Overall, the study, now the full-scale study, is called Predict, and the setting is the OCHIN network of community health centers. And this is a network that serves about 6 million uninsured and low-income people around the country. And what's great about this network is they have a centralized electronic health record. So they really specialize in these studies where there's an EHR intervention that they can turn on or off at different clinics around the country. And then the hope is that if it's effective, if it's useful, if clinics like it, it can be scaled up across the network. So, even if it can't be generalized beyond that, the impact just within this network to us seemed really appealing as, a potential something down the road. So we did go ahead and develop a new model in this setting. So we used historical EHR data from OCHIN patients to predict incident HIV using a machine learning algorithm. And then I'll go into more details in just a minute, but just as an overview, we embedded the model into a clinical decision support tool for PrEP that then was implemented in the centralized EHR. And we piloted that at 3 clinics around the country. And now we're conducting a full-scale trial in 16 clinics. And the outcome is PrEP prescribing. So just from the pilot study, so we developed a model, and then we really focused on trying to maximize both accuracy and fairness. So here I'm showing the ROC curves for our model by sex and race, and you can see that there are disparities in how the model performs. And so just to say, first of all, the model used data from 1.7 million patients, performed very similarly to the models we had developed in the past. The final model had 51 variables. In retrospect, and I will tell you these lessons as I go, in retrospect, I would keep it much simpler, even if it sacrifices some predictive accuracy, and even if it sacrifices some fairness. And I'll go into this more later, but I really think the complexity is a barrier for providers trusting the model. It's not the Framingham risk score. It's not like I can tell you the 5 variables and you can calculate them on a piece of paper. It's a little bit of a black box. And one of the reasons it got so complex is that we wanted to maximize fairness. And so we added interaction terms by sex and race to the model. And that improved performance, but it also added a lot of complexity that made it challenging to implement in the EHR and challenging to, it limited our ability to be transparent about what is triggering these alerts for specific patients. And that has been a barrier to providers buying into it. I'll also say that even if you maximize fairness in a model, it doesn't mean that the initiation of PrEP discussions, that those decisions by providers are going to be fair. And so we actually have an aim built into the full-scale study where we're really going to explore how do providers make those decisions when they see these prompts. What are they thinking about? Are they looking for specific factors in the electronic health record where they'll say, okay, like I will have this discussion with this patient. And how do they make those decisions? So we developed this model, and then we selected a model threshold where we say above this point, we're going to prompt a provider to talk about PrEP with this patient. So how do you select a model threshold? This graph is giving you an example from a very different clinical setting, just to make the point that of how different PrEP is. So this is a graph looking at the predicted risk of malignancy, and this is for ovarian tumors. So here, we'll talk about positives and negatives. Like if you miss a positive, that's really bad. And that's like very different from the PrEP setting. So in any setting where you're trying to predict something, the ideal is that there's no misclassification. So every single time you flag somebody, it's somebody who would have gone on to get HIV or would have, or did have a malignant tumor. And the flip side is also true. When you don't flag somebody, you're not missing anything. But the reality that doesn't happen, right? The reality is there are false negatives and there are false positives, and that's just how it works. So in choosing a risk threshold, you can minimize misclassification, but if you look at where the red box is on the graph, you're missing a ton of malignant tumors if you're just minimizing misclassification. And so you want to think about what does it mean to miss a false positive or to miss a positive in this context. So you have to think about values and morbidity and mortality. And so here for ovarian tumors, the utility-based threshold is in a very different place from the threshold where you're minimizing misclassification. In the context of PrEP, the stakes are much lower, not because HIV is not a bad outcome, but because the cost of having a conversation about PrEP when the patient would not have gone on to get HIV, I mean, that's actually standard of care, right? Like for most patients, anybody who's sexually active, the conversation should be happening anyway. And missing someone is not the same cost as, so missing someone who would benefit from PrEP is not the same cost as missing a malignant ovarian tumor. And so we had to kind of think, it turned out to be more of an art than a science. We had to think through all of this. And then we also had to bring in provider input and clinic input on what they would tolerate in terms of how many prompts their providers were going to be okay with. And so we actually ended up moving the model threshold after implementation. So I'll go into that in a second. But the next step was collaborating with the providers and with EHR specialists at OCHIN to develop the tool. And this is the pilot version, so you'll see the later version in a minute. But the basic structure was there's a notification that a patient may benefit from PrEP. And they get information about the prediction model, about PrEP. There's a smart set that gives them language to frame the PrEP discussion. And then tools for diagnoses, lab orders, et cetera. Diagnosis codes, automated notes, just trying to make it as easy as possible. And that there's also, it shows up in the health maintenance section, and this is all in Epic. And it shows up this is my favorite part, actually, that it shows up in health maintenance, just like that dashboard I showed you for Kaiser, where it's just integrated among other preventive care services, just like flu vaccine, PrEP discussion. This actually got removed from the final tool that we're now implementing, but I wanted to show it just because I think it's helpful framing around a PrEP discussion. So we use the goals framework for sexual history taking, which is really focused on normalizing PrEP, empowering the patient, focusing on benefits more than risk, centering users' values, and not forcing the patient to disclose things. We don't have to ask them a million questions about all the sex they're having and their partners and whatever. You can just say, here are the people PrEP may benefit. And then the patient can say, oh yeah, it sounds like it's something I would like to do. And done. You don't have to go into any details. Okay, so some successes of model implementation with a few quotes that I might not read through, but just so you can see them. So we heard that the tool helped providers identify people who they might otherwise miss because they're busy. That's, kind of one of the basic ideas here. So that was good to hear. The tool supported discussions of prescribing for providers who were less familiar with PrEP. They felt like all the information was there. They could click through it. And it prompted providers to initiate discussions about PrEP when stigma was a barrier to patients initiating those discussions. So two of the clinics where we implemented this were in pretty conservative areas. And so there was a sense that this tool kind of overcame a little bit of like the cultural barriers that might have been there for providers, for patients and providers starting these conversations. Also, we weren't expecting this, but we heard that it increased communication and relationship building between providers and clinic staff, that they had this thing to talk about. But that was not the goal, but an unintended consequence. All right, so some challenges. Some providers believe that the model was identifying patients who were not likely to benefit from PrEP, so we'd call these false positives. And this, I would say, is the major barrier to implementing a tool like this, that providers have I don't want to generalize. Some providers have, and not in San Francisco, right? But like, think about like North Carolina or wherever, providers might have some idea of what a PrEP candidate looks like. And beyond that, if an alert appears, they're like, this person's not going to benefit from PrEP. Your algorithm's wrong. But the whole idea with the algorithm is we are overcoming these sort of boxes of like, okay, gay men and STIs with data that's like the tool is telling us, based on the epidemiology of HIV in this patient population, this person in this particular demographic group, in this neighborhood, whatever, is likely to benefit from PrEP, but a provider sees that as a misfire. Some providers believed that the model was missing patients who were likely to benefit from PrEP, so these would be false negatives. So there were some cases where the person did look like a PrEP candidate and did not get flagged, and that reduced trust in the model. And some providers were hesitant to act on alerts without more information about the specific variables that prompted alerts for each patient. And I would say this question has taken up a disproportionate amount of bandwidth for this project of, do we provide variables on why the alert fired for a specific patient? And we have reasons that we talk about in this paper that's cited at the bottom, reasons why we decided not to do that, even though providers were asking for it, largely around the kinds of conversations that we were imagining they would start. If there were certain variables appearing for a specific patient, there were concerns around these conversations being stigmatizing, and we had no control over how those conversations were going to go. And so we said, okay, we're just going to ask them to trust us on this. That did not, I don't think that worked. Like, I really think that they were like, I, as a provider, need to know why this is here, and I'm not going to act on it otherwise. And just zooming out, this is a question not just about PrEP and PrEP-related tools. This is like, you know, AI is going to be everywhere in healthcare, already is. And how is this going to work for providers? How is it working in terms of trust in these tools? Like, what is it that makes a black box tool trustworthy? And I don't know the answer to that question, but that has become kind of the central focus of implementation for this project. Okay, so we started with a very generous threshold in terms of where we were flagging people for discussions about PrEP. And based on feedback from clinics and providers, we became much more conservative. So we ended up flagging about 2 to 3% of patients as likely to benefit from PrEP. And these are patients, remember, this is a population that's already at elevated risk of HIV compared to the general population. So we're really flagging patients at very increased risk of HIV. So going back to this idea of like what a PrEP candidate looks like, this is a specific case that actually came up where a provider contacted the study team and said, your model is wrong. This patient was flagged as likely to benefit from PrEP. Married to a male partner, cisgender woman, drinks alcohol, lives in LA, identifies as Latina, and had an HSV2 diagnosis years ago. So based on the epidemiology of HIV in this patient population, this woman is at increased risk of HIV and might be a missed candidate for PrEP in the absence of a tool like this. But this provider believed that the model was wrong. And should the clinicians prioritize PrEP? So we ended up asking this question of what happens if you just rely on STIs? Because the providers often were like, well, she doesn't have an STI other than her HSV2 diagnosis. She doesn't have a recent bacterial STI. Why should we talk about PrEP? And this is kind of getting into heuristics versus rational thinking. So what we did was we actually looked at the data at OCHIN. So over many, many years of many new HIV diagnoses, only 2% had a prior bacterial STI. So you had missed 98% of new HIV cases at OCHIN by only relying on STIs as a predictor for who would benefit from PrEP. So we've fed this information back to providers in the hope that it could help with understanding what the strengths of the model are. And I will say, working through OCHIN has had its benefits, but also has kept us fairly removed from clinics and providers. They're very protective. They don't want researchers to be, taking up the bandwidth of clinics and providers, which I get. They're protective. But it also means that we've had limited time to provide education about PrEP and about the model. We've had some, but definitely not as much as we would have preferred. And so I think that could have helped with framing, here's how this model can help, and here's why some of these prompts might not look right to you, but might still be worth considering. So we actually took their heuristics and integrated them with the model. So we created what we called a blended model, where on the left, we have all the variables that were just automatically retained in our model. And then on the right, we created these rules based on the provider heuristics of who they thought that would benefit from PrEP. And we actually said, okay, we will flag a patient if they meet either our model threshold or they meet any of these rules. And this actually had lower specificity than just relying on our prediction model. And it runs the risk of reinforcing current prescribing patterns. But we felt like if the providers don't trust the model, it's not going to have any impact at all. And so we have to do whatever we can to improve trust and engagement. And so we actually did bake in their heuristics about PrEP candidates. We added a provider-facing model facts label, and this was modeled after a paper by Sendak, who created this sort of nutrition facts label for models. I doubt providers ever looked at this, but all the information was there if they wanted it. In terms of showing them the patient-specific predictors, so I mentioned we were concerned about how they would frame discussions. There were also predictors in there that were just not intuitively linked to HIV risk. So for example, missing data on payer was a predictor of HIV, incident HIV, and that's a proxy for risk. That's a social determinant. That's like a proxy for a social determinant. But if a provider sees that and we say, here's why you should talk to this patient about PrEP, it requires some context and explanation. And we just felt like it became one more reason to not provide these specific variables. Also, it was going to be really resource intensive to program, partly because the model ended up being so complex. All right, so now we're doing a full-scale trial, and this thing I'm showing you on the right is not what an actual prompt would look like, because here it's including, a ton of possible diagnoses that could show up. So this is and demographics. Any given prompt is only going to have a few of these. But we really streamlined the recommended actions. Other things, we worked with patients and providers, got their feedback, incorporated lessons from the pilot. So we ended up framing the tool more broadly around HIV and STI prevention, not just around PrEP. We did add some patient-specific variables to alerts. We streamlined the content. We integrated DoxyPEP because that emerged in the meantime. We added an option for providers to refer to a PrEP champion at their clinic, so they didn't have to be the ones to prescribe PrEP if they weren't comfortable. And we added an option for clinics to message patients directly. We worked with a patient engagement panel on the language for that. So now we're evaluating impact on PrEP prescribing. We're about halfway through. We've enrolled 5 of 8 wedges in the trial. We're getting, I would say, mixed reviews, and I would say anecdotally that it seems like, and this was actually something that we found when we implemented our model at Kaiser San Francisco, that the providers who are familiar with PrEP are that there is an impact on prescribing among those providers. The ones who already, let's say, have HIV patients on their panel, they get this whole world. The ones who are less familiar, it seems like they might need a more upstream intervention than a tool, what a tool can provide. But that's just my anecdotal midway preliminary take. Don't quote me on it. And yeah, and then for our AIM-3, we're exploring decisions about PrEP discussions. We're actually about to launch interviews where we're enrolling providers who have been exposed to the tool and just trying to understand their decision-making process. So just to go back for a minute to this question about adding patient-specific variables to alerts. So this, we've been able to add some variables to the alerts, but because we haven't been able to add all of them, and that's due to the interaction terms, going back to this complexity issue, I really feel like it's actually made things worse, not better. The providers are getting some variables, not others. It's just, if you're going to do this, keep it simple. That's my recommendation. And if you're going to develop a clinical prediction model in any setting, for any reason, really be thinking from the very beginning about what's going to happen when I implement this, which is perhaps obvious. And I know that I'm talking to some implementation science experts here, but as a postdoc, when I first developed this model, I was just like, yeah, let's create a model and maybe it'll help us identify people who can benefit from PrEP. And I had not thought through what are the actual variables to put in here? How is that going to land for providers? And I really think keeping these simpler until providers are willing to trust black box tools is the only way to get engagement. Anyway, this strategy is being implemented at various places around the US. We have a study that's ongoing in the Dallas County Jail. The Massachusetts Department of Public Health is using this in practice with community health centers in Massachusetts. And we did a trial at Kaiser San Francisco, and everybody's using different implementation strategies and various levels of community engagement. And I think, we're hopefully going to converge on what is the best approach here. As I said, there's some skepticism about this approach. This is an old article, but this is from when we first published our models. And she was really raising this question of like, what are patients going to think if they know that you're using their data for this, nefarious purpose? And she was really framing it as like, HIV is this special case and it's so sensitive. And we were like, yeah, but there's a way that that's true, but that also perpetuates the stigma around HIV. And this is actually routine care. And we're doing this all the time for other conditions. But of course, we need to be sensitive about how we implement these tools. And so just, I'll put up a few ethical considerations and then I'll open it up for questions, and really looking forward to hearing what you think. So there are questions about bias, of course. So it doesn't matter how much you try to improve fairness and model performance, your algorithms are always going to retain bias from the data that they're trained on, and training algorithms on electronic health record data are just inherently, it's inherently going to carry the bias of what is happening in routine healthcare engagement, and then also how people are recording things, billing, there's so much baked in there. There's the potential for stigma. So as much as different teams have been engaging community and end users in tool development, we can't guarantee the fairness or the patient-centeredness of ensuing discussions, and actually they could be stigmatizing. There's a question of accuracy. So discussing PrEP as standard of care, but alerts that are perceived as inappropriate might not be received well either by providers or by patients, given the sensitivity of HIV. And then there's questions around privacy and consent. So some patients might not want their EHR data used for this purpose without their consent. But I would also say at the same time, that has to be weighed against the sort of ethical responsibility that we have to try to improve PrEP access. And that's particularly true for underserved populations. So doing nothing also has ethical implications. Some conclusions: I do think these tools have the potential to improve efficiency and equity in PrEP discussions and prescribing and primary care. strategies are needed to improve trust in these tools, and I think that goes well beyond HIV. And anecdotally, I think this is particularly true for providers and clinics that are less familiar with PrEP. Um, I think we need to consider all these ethical issues, which I think are hot topics as AI and machine learning get further integrated into healthcare. And I think we need innovative delivery pathways that go outside of these traditional clinical settings. So actually, we have a project on over-the-counter PrEP that was sort of born from working on this, where we were like, can we just go around the providers? It's like we've spent years trying to get providers to talk about PrEP, and then we were like, what if we just circumvent them? So then the project on over-the-counter PrEP was born. So yeah, I'll leave it there. These are the acknowledgments of our team at Ocean and Harvard, OHSU, and our funding from NIH. Thanks for listening and happy to take questions.
Wow, that was amazing. Thank you so much. Ugh. I actually have a bunch of questions now, and I'm opening up the floor to other folks who may have questions. If you want to either raise your hand, put your question in the chat, or come off mute, those are all great options. Thank you so much, Julia. That was amazing. I actually just want to start the questions off, if it's okay. I'm wondering if you can talk a little bit about, because you said the upstream interventions I totally, first of all, agree with circumventing providers as well. It's like kind of been what most of my projects have been about. But I'm just wondering if there's any thought about like providing training for providers, particularly around like stigmatize, because that one of the things you mentioned was around how there might be some stigmatizing language if you fed them what went into the algorithm. I guess I'm just curious what sort of like guidance or training could be done for providers ahead of time so they understand the data and how they can feed it back to their patients.
Yeah, I mean, we would love to get more time with providers, and we do offer some education. We are very much on call for them. If they have any questions, they can just, I mean, Doug Krakauer's co-leading the study with me, and we're at the ready to answer any questions they have. But we've gotten very little structured FaceTime with them. And I think a kind of one of the many bottom lines of this line of research is that you really need, with a tool like this, a lot more kind of wraparound education, not just about PrEP, but really about what the tool is doing, what its strengths are, what the data all mean, how it works. So yeah, and we've also thought about for the upstream interventions in the clinics that are not yet ready for a tool like this, that really have done very little PrEP implementation, or less familiar with it, less culturally comfortable with it, that, taking Fenway's model of providing education and bringing that to these community health centers is probably a more effective approach than bringing them a tool that's, I think, a much more downstream tool.
Yeah. Yeah. John, I think I saw your hand raised.
Yeah, thank you for the talk, Julia. It was great. Um, I, yeah, I'm fascinated by this idea of why some providers, obviously, if they got HIV patients, then they're going to be more familiar, and but why some trust a model like this versus people who don't. So, like, I have a colleague who's in nephrology who uses AI for almost a lot of his clinical decision making, and just is not ashamed about it. He's like, yeah, I do it for this. I look up this, I type it in, and I'm trying to figure out like what is that difference? Is it the only idea I could come up with? Are we more willing to use it if it is convenient for us? And if it's not yet convenient for somebody, is that where you get that hesitation? Because I'm assuming you could easily do like an early adopter, late adopter kind of thing in terms of assessing where providers are at individually. But I'm fascinated by if you guys have been thinking about like why that is that some are more likely to take it up and use it and others aren't.
Such a good question. I think it's fascinating. I don't know the answer to the question, but I think it would be great to do. I'm sure there is research happening on that outside of HIV. I would love to do some of that research within this context. To really understand if that is what we end up seeing, that the clinics and providers that are more familiar with HIV were more likely to trust and use the tool. I would love to do some follow-up on that to understand why that is. Is it about their willingness to trust the tool? Is it about having more flexibility in their idea of what a PrEP candidate looks like? Is it about just being more comfortable with, like, I think there is a little bit of a, don't tell me what to do. I have the best, clinical intuition. I don't want a machine telling me, what I should be doing here. And we framed it as this is a screening tool, like a first stage screening tool. It's not telling you you need to take this action. It's telling you consider a discussion about PrEP. And I do think there are AI tools in healthcare that are much more, like around sepsis or whatever, that trigger a whole cascade of events. And this is not that. But there may still be some, I don't know if it's even like personality differences or like.
Right. Yeah, for
That.
sure. But I mean,
Well,
it's like also just the challenge of the provider doing more. I literally just reviewed a colleague co-author's paper on sort of the same thing, but for prescribing statins for people with HIV. It's sort of the same kind of idea of like giving them the algorithm score, automating the risk. But I'm like, okay, then they're going to do this and then they're going to do that. So anyhow, just thinking creatively, but this is great. So thank you.
Well, I just wonder also if providers are worried they might be sued, like if they don't do anything about the score and the person does seroconvert, then it's like, well, there was this thing that told you to put them, get them started on PrEP. So I wonder if there's also a fear of that. Julia, I was wondering if you can talk a little bit about also the AI or like how you who on the team, helped you with the actual programming and how that experience was like. Because I know we're still learning as well, so it would just be really helpful to get a better idea of how you all went about that.
Yeah, I mean, this is like kindergarten level AI. Like it's baby AI. It's like we're using a machine learning approach, but it's interpretable as a regression. So it's not, this is not high level stuff. But I do think it's relevant in the context of thinking about AI for the use for HIV prevention and the kinds of barriers that people may run into trying to implement this kind of thing in clinical care. Our programming and all that was done by a team at OHSU, a biostats team that works with OCHIN on these kinds of interventions. So they have experience with this. And then in terms of like programming it into the EHR, it was like a EHR specialist at OCHIN who did that for us.
Great. Folks, please feel free to come off mute or raise your hands or put your questions in the chat. Otherwise, I'll keep asking my questions.
Well, I got another question for you.
Yeah.
Julia, for your R01, how much of it, if you don't mind, was this AI piece in terms of the back end sort of innovations there? Because I think or at least myself, and I know we've had discussions within within CAPS and DPS, is just sort of the level of the technical expertise we need to do this type of work. But it's often like, we don't need a PhD in computer science per se, but you need somebody who can bridge that gap. And I'm interested in hearing about how you framed that, because you could obviously critique and say, hey, you don't have somebody does it on your team, for example, I'm doing a project, you don't have the expertise to be building these models. So how did you sort of pitch that story in terms of being able to pull that off? Because I think that's something we struggle with, is just how much to lean into it, but then the reality of there's just too few experts who on paper, can say, I build these models and I do public health behavioral kind of
Yep.
research.
Yeah, it's a great question. I think it didn't really apply that much to us for two reasons. One was that we used the model that we'd already piloted in R34. So the actual like development of the tool, the framing of that was in an R34, and that was really because it's because it's not like complex AI. We didn't really need to make a case that we needed somebody beyond an experienced biostats team. But yeah, I mean, I could see that running into that question of expertise, and maybe our teams need to be getting more multidisciplinary. I don't know. I mean, I think we have few experts embedded in our field who can do this kind of work at this point.
Mhm. Julia, Kobe's also asking if there was any conversations around pop-up fatigue. He says, I love the idea of putting in health maintenance.
Yeah, definitely. There have been conversations about that. When we did qualitative work with providers at Ocean and asked them about their workflow, we got, we were like, should we put it here in the EHR? Should we put it here where it would work for you? We got like exactly opposite answers. So some of them felt very strongly that it should be in this place in the EHR, and some of them were like, I never look at that place, like it should be here. And so we're like, who knows? So we ended up putting it in multiple places. We don't force them to do something when the prompt appears. And yeah, I'm with you. I prefer it being in health maintenance. But I think having it in multiple places is like the only way to get the attention of providers across many clinics that are using different workflows. In terms of pop-up fatigue, that is partly why we changed the risk threshold, that providers just are seeing so many of these that they wanted to see fewer, and we felt like if we narrowed the threshold, it was going to increase specificity. So the prompts they were seeing were going to be better fits. Like it was going to look more and more like a PrEP candidate for them. And so we felt that would also potentially increase trust.
Thank you. Actually, maybe if you wouldn't mind also just saying a few words about your over-the-counter PrEP project, because I know it's not related to AI specifically, but very fascinating as well for us.
Yeah, our Go Around the Gatekeeper project has been so interesting and fun. And like it's like the little project that got terminated, and then all the cohort studies that we were using for serving, they all got terminated. But somehow the project it just like keeps going, and we've learned that interest in over-the-counter PrEP is high, very high among trans women, gay men, and cis women, and that people, I mean, we're still analyzing and publishing data, but this is like a snapshot, that we have a sense of what people would be able and willing to pay out of pocket for monthly over-the-counter PrEP, whether and how people would access HIV and STI testing if they were using over-the-counter PrEP, reasons why they would or wouldn't want to use it. And then we've seen some of our hypotheses really borne out about who it would be likely to benefit. So for example, trans women who have either anticipate or have experienced discrimination in healthcare settings when they talk about who they have sex with, those folks are like really on board with over-the-counter PrEP. Like almost 100% of them say they'd be interested in using it. Also, people who are concerned about privacy on their parents' healthcare plans, if they're on their parents' insurance, they want other ways to access PrEP where it's not going to be documented. And that had been a hypothesis that really has been borne out in the data. We're also doing modeling. It just got published actually like yesterday. So I'll put a link in the chat. With Sam Janessa's group at Emory, just to understand what would be the potential risks and benefits of this approach. And it's a mixed bag. I mean, obviously, if you pull back on testing, you're going to see some increased safety concerns, but then also there's a trade-off with potential increased access to PrEP and reduced HIV infections. So we were really trying to explore that. And then we've also done a lot of interviews with stakeholders of all different sorts, and we're analyzing that data now too. So basically everything's like forthcoming, but it's been a really rich project, really fun.
Amazing. Thank you so much. If there's no other questions, we can and a few minutes early. But I hope if it's okay if folks reach out to you directly if they have additional
do.
questions. And thank you again so much. Amazing presentation, and please come back and present for us again.
Thanks for having me. Good to see you all.
Thanks so much. Nice meeting you again. Take care. Thanks everybody for joining.
Bye.
Bye now. Thank you.